crisis stabilization programs and expand our global crisis department and co-response team. I do have over 10 years of experience in behavioral health, from psychiatric ED to outpatient mental health, as well as methadone programs. I had the pleasure of creating, with a team of folks, certified community behavioral health clinics. So in my, as a director, I look forward to hearing from you two as the experts up here and drawing from just some of my experiences. So during this session, what we'll do is we'll hear from two speakers who will give us some information from two vast different kind of points, but yet it is underneath behavioral health. So we're excited about that. The goal of this session is to share some of the ongoing challenges counties face in the provision of behavioral health care and highlight some innovative solutions. Yes, innovative solutions, because we're all in this together. At this time, I am honored to introduce you to two speakers who will share their insight. And when I get done telling you what the bio is, you all better have some questions, because we have some experts up here. So it is my pleasure to introduce Ms. Marissa Malik, the Director of Texas Integrated Care in Travis County, Texas, and Judge Stephen Leifman from Miami-Dade County, Florida. Ms. Marissa is the Practice Administrator of Crisis Services at Integrated Care, the local mental health authority of Travis County. Since joining Integrated Care 9 years ago, Marissa has contributed to their mobile crisis services, psychiatric urgent walk-in services, and crisis intervention training for first responders. Ms. Marissa has played a key role in bridging the gap between behavioral health services and emergency medical services and criminal justice systems. Isn't that impressive? Most recently, she has contributed to the work of integrating clinicians into the 911 call center in order to ensure that individuals in crisis receive the right care at the right time. Yes, you heard me, the right care at the right time. You can clap for her. Now, we have the Honorable Steve Leifman. Now, you ready for this? He is the Associate Administrative Judge of the Miami-Dade County Court Criminal Division. He previously served as Special Advisor on Criminal Justice and Mental Health for Supreme Court of Florida, and currently chairs the Court Steering Committee on Problem-Solving Courts. Additionally, Judge Leifman is a member of the Conference of Chief Justice and Conference of State Court Administrators, National Judicial Task Force to examine state courts' response to mental illnesses. He serves on the Interdepartmental Severe Mental Illness Coordinating Committee. He is a lecturer, a professor, an author, and award winner. Notably, in 2015, Judge Leifman received the William H. Rehnquist Award for Judicial Excellence, one of the national highest judicial honors. Look at that, the highest, right? Oh, we're not finished yet. We're not finished yet. He is also the subject of a documentary, The Definition of Insanity, which aired nationally on PBS on April 14, 2020. Look at that. Let's give him a clap. Yeah. It's amazing. So this is what we're going to do. I'm going to ask him some initial, just some initial statement, and then what I'm going to do is then ask them one question. But then I'm going to stop talking because I want to hear from you all. We want to hear from you. So get ready to get your questions together, please. I'm sure there's pens at your table. If not, use your cell phone, text yourself some questions, okay? So, initial remarks. We'll go to you, Ms. Miles. Yes.
Good afternoon. Thank you so much for having me today. Again, my name is Marissa Malik. I oversee crisis services here in Austin, Texas. Thank you for joining us here in our wonderful city, despite the heat. I hope you're enjoying it. I am so happy to be here to talk about our crisis services. This past year and a half, we've seen a lot of changes in our workforce due to challenges that we've been seeing with recruiting and retaining. So I'm happy to be here to talk about some of the strategies we utilized, as well as partnerships that have helped kind of ensure that we're able to sustain our projects, to ensure that people in our communities are getting the right care at the right time when they're experiencing a crisis.
Thank you so much. Judge?
Thank you, and thank you so much for the opportunity to be here. And I really wouldn't be able to speak about the amazing accomplishments we have made in Miami-Dade without the remarkable and incredible support of my Miami-Dade County Commissioners. Commissioner Heyman has been around this week, and there are other county commissioners from my county here, but none of this would have been possible. And we really believe we have put ourselves on a path to fixing this problem, because it is fixable. You know, it's sad that as a criminal court judge, we see more people with serious mental illnesses in a day than most psychiatrists will see in a month. And I think what you learn after several years on the bench is that in many ways, the criminal justice system is the repository of many failed public policies. And there is no greater failed public policy than our treatment towards people with mental illnesses. The fact that we have applied a criminal justice model to an illness explains why we have failed so miserably. But the good news is this is very, very fixable. My county right now, even with all the amazing work that we have done, still has about 2,400 people with mental illnesses in its jail. They spend $636,000 a day, that's $232 million a year, to warehouse these 2,400 people. Compare that to the state of Florida, which spends $47 million for 34,000 people, leaving 70,000 people without any access to care. And it's not just about money. The system is painfully fragmented, it's horribly overburdened, it does not always use best practices, and it really doesn't work. And so we started in 2000 with the summit, where we invited all the key stakeholders to a 2-day meeting. And I think one of the best things about being a judge is that when you invite people to a meeting, they come, even if they don't want to be there. And so we had our county commissioners, our sheriff, our state attorney, public defender, law enforcement, Department of Children and Families, all the essential stakeholders that can make policy changes. And we spent the first half day just mapping out the intersection between our community mental health system and our criminal justice system. And what we found is that we were embarrassingly dysfunctional. We had created a system to fail perfectly, and it perfectly failed. And I think what's so galling, and what we often find so galling about this, is that we then blame the people who fail in a system that isn't working for them. And we end up punishing them in a criminal justice system that often makes matters worse. And so what we've been able to do over these last 23 years as a result of this summit is we put together a written collaborative agreement, because this is all about collaboration. And we set up a pre- and post-arrest diversion system. Our pre-arrest system is based on crisis intervention team policing, 40-hour training program that teaches law enforcement how to identify, de-escalate, and not arrest. We have over 8,300 officers trained in Miami-Dade at all 36 departments. Out of 105,000 mental health calls, just for 2 of our 36 departments over 10 years, they only made 198 arrests. The number of arrests in Miami-Dade went from 118,000 a year to 53,000. Our jail audit went from 7,400 to 4,400. We closed one of our 3 main jails at not a shifting, but a cost saving so far to our county of $120 million. And that's why they've been so supportive. But what you will find is when you do all this great work, the community mental health system in America was really designed for people with moderate mental illnesses, because the people with the most severe and acute illnesses were in state hospitals when we developed community mental health. And so when we went to the war on drugs and crime, when we closed our hospitals, when we went to sentencing guidelines and we did massive housing cuts, this population got thrown out into a system that was not developed for them. And so what we are doing now is developing a new system, and I really want to talk about it in a minute because I know my 5 minutes are up, but we are just about ready to open the first of its kind mental health diversion facility. It's a 181,000 square foot facility. It's the old competency restoration facility, so we're going to use it for something useful. And it has every essential element of recovery for this population. So it has a receiving facility, crisis stabilization, short-term residential, primary care, dental care, eye care, podiatry care. It has a courtroom to manage criminal and civil cases, vocational, educational programs, and 208 beds of housing. And the idea is for this most acutely ill that continues to cycle again and again, is to offer them what they actually need. And instead of just kicking them to the curb once we've adjudicated their case in our criminal system, we can gently reintegrate people in recovery with the supports that they need to maintain their recovery.
Thank you. Thank you. So, so if you have questions, please start coming up. But I am going to ask another question while people make their way to the microphones. We have 2 microphones on the side. I'm known to call on people, so please come up to ask questions. Ms. Marissa, so what's your experience, just your remarkable experience with mental health? Can you talk to us, especially right now, we're in a room, in a space with a lot of elected officials, right? Are there ways that county officials can better support your role or reduce the barriers you and colleagues experience?
Yeah, I think that's a great question. What we've experienced the last few years is just a lot of workforce shortages. So I think that lifting up the services that we're doing to ensure that we can continue to provide the services and sustain the services is beneficial. I'm very fortunate to be here in Travis County to where our government officials, specifically our county commissioners and our city officials, have been able to uplift our services and have been able to really support the services that we've been doing. So we have a pretty robust crisis system. We have mobile crisis outreach teams. We have a 24/7 crisis helpline who also takes 988 calls for our county as well as the 76 counties in our area. We also have a designated mobile team who partners with first responders, law enforcement, and EMS, and that is specifically because of our government, so our city officials and county commissioners funding those services. So in order to sustain those services, that was really helpful in ensuring that we're able to do that. They also saw the benefit of our services here in Travis County and integrated our clinicians into our 911 call center. And that was to get the most upstream in the process and diverting police response when there was not a public safety issue. So that's been really beneficial in our community, and I'm very proud to say that we are the first city in the nation who added mental health services as an option when people call 911. So that really reduces the stigma and ensures that people are getting the right care. And you know, Austin's not a very, it's very expensive to live here in Austin. And so our agency just went through a class compensation. We did a cost of living. We ensured that we were providing our clinicians with a crisis stipend. So ensuring that we supported the compensation to value the work that they were doing so that we could continue support efforts for them in the community, and all that comes at a cost. And so ensuring that we were able to do that is really beneficial in ensuring people are in those positions to meet the needs of the community, and that's all been helpful in ensuring that our governmental agencies are supporting those costs to support the wages for our community as well.
Thank you so much. Commissioner, you have a question?
Yes, Judge, it's good to see you again. We have actually gone to visit his program, and when you look at it from top to bottom, the way that they have found the facility, expanded the facility, found a way to fund it in a conservative state, but understanding that if we divert people from jail, we save significant dollars and ultimately can do more to help get to a cure. But my question is more about how you use your model to take folks who have lived experience and train them to work within your system, because we have significant labor shortages, whether we're talking the jails or whether we're talking, well, any aspect of police force. How do we make sure that we are addressing the needs for staff by identifying people who have lived this life, have gone through a therapeutic process, and now can help someone in ways that maybe you couldn't help them if you didn't have that experience?
Thank you. Peers are a critical, essential element of the success of all of our programs. We often say that our peers are the secret sauce of our recipe. And it's not that, hey, I have mental illness, you have mental illness, we combined. What we have learned is that by the time individuals with serious mental illnesses do end up in the criminal justice system, they have what is called learned helplessness. The system is so bad that it has actually taught them to give up. And what the peers do is it helps reestablish relationships, which then incentivizes them to want to get better. And it is a really critical part of our program. Now, we're short-staffed right now as well, but at our height, we have about 25 members on our staff. And 8 of our 25 are people with lived experiences that serve as peers. And for the new facility, there will be peers there as well. But it does also help with the workforce. And, you know, we just had legislation passed in Florida this last session to make it easier to hire peers with criminal justice backgrounds. But as a court, we are not under some of the restrictions that the state has. And so we've set up our own criteria to hire individuals with prior offenses. In fact, half of our peers are graduates of our program. And it's just a wonderful way to help identify individuals.
Yes, we have another question. Hello? Microphone is off.
Now it's on? Okay. Good afternoon. Thank you for being with us. Ms. Marissa, you talked about the mental health professional being embedded in your 911. Could you talk a little bit more about that? And then also, have there been any conversation or thoughts about using peer specialists within the 911 centers? But especially, is it a professional on all 3 shifts, and exactly what they do? Thanks.
Yeah, thank you. Yes, we have a team of 19 professionals who are integrated into our 911 call center. The structure for those positions are licensed professional counselors, social workers for leadership, and our team leads who are providing the oversight of the clinicians, and then we have what we call qualified mental health professionals. So at least a bachelor's level degree of experience with health and human services experience. Currently, we don't have any peer support specialists within our 911 call center, but we are looking at integrating peers within our services at the 911 call center, our peers are currently only providing services on mobile crisis. So when we are providing a referral out for a face-to-face community response. But our clinicians at the 911 call center are 24/7. They are running 12-hour shifts, so they work 6A to 6P and 6P to 6A, and that's really, it was a lesson learned for us. We primarily used to work 4 10-hour shifts, and we found that 12-hour shifts were more desirable for call center experience. And it also helped with workforce shortages. You can have more coverage with less employees with the 12-hour shifts. So that's currently what we're doing right now. And our goal is really to ensure that we are providing crisis screening and triage. So our goal is to receive the call transferred from the 911 operator who has deemed the call that there's not a public emergency, safety, or medical emergency needed. They will transfer the call over to our clinician, and we do that screening so we can ensure we're getting the right care to that person. Our average time on the phone is about 14 minutes. So it really is a screening and triage function. And most of the calls that we have, they're resolved over the phone. I would say about 80% of the calls where we're doing emotional support and de-escalation services. And then about 80 to 85% of the calls that we have, we're diverting from police response. So of the calls transferred over to our clinicians, 85% are being handled by our call takers with a disposition that does not involve being transferred back to police response. So it is a really good service if you're able to do that within your community. Huge cost savings as well. We did a cost-benefit analysis to ensure that we were looking at what that looked like, not only for the person getting the right care of service, but of the calls that we've been able to divert. We did a cost savings of about $12 million last year. So that was looking at what we were diverting from both police and emergency medical response. So it's been highly effective, not just from the cost savings perspective, but also from the person getting the most appropriate treatment when they're in a crisis.
Any more questions? Oh, yes.
I'm Cindy Mills from Forsyth County, Georgia, and when Commissioner Tanner was up there, I wish he could have had the chance to talk about workforce, because even though we have very limited amount of beds in Georgia, most of the hospitals that we do have, we can only access half of the beds because of the severe work shortage. And I think this is where NACO could really help us to see what states are bringing forth and what colleges are bringing forth, that we can get more people to help people, because we can have the best ideas in the world and we can produce some fine facilities, but without the people to work inside of them, as you've already mentioned, it's we've not accomplished a whole lot. We can't move the needle.
So thank you for that question. Yesterday we had, I'm very fortunate to serve on NACO's Mental Health Commission, and we had a meeting yesterday, and the whole meeting was centered on workforce development. And one of the ideas that came up at the meeting was to talk about maybe seeing if we could get some kind of national service program, because this is a huge problem. The providers that spoke to us yesterday said that they had anywhere from 30 to 60% vacancy rates. And it's unsustainable. And the rural areas are just getting devastated. They can't get anybody to work there. And telehealth, while it's great and it's an improvement, it's still not enough. You still need social workers. You need to help people navigate these complex systems. And so it's going to take a much bigger initiative to address this. And one way to do it would be to have some kind of national service program where the government could help fund the educational programs, and then the individuals would give back a certain amount of years, where then they could be placed into the rural areas or even urban areas that are also just as short and help make up this huge gap so that we can start to serve more people more quickly. But I will tell you, part of it is you can do some things that can home grow. I mean, we started looking at this issue 15 years ago. We got Jackson Memorial Hospital to fund a fellowship program for psychiatry for our program. And so they, every year, get a new fellow in, and then we recruit that person to come work for us. And it has helped tremendously. This new center that we're opening, we will be offering residencies, internships, and we will use it as a workforce development program to help hire. And part of it isn't just numbers. You need highly qualified people for these positions because these are complex issues. And you need people that both care and are competent to do the work. And so we hope to use the center to raise that level of competency for the individuals and help them work in our communities.
Okay. Part of that meeting yesterday, we also, some of the providers talked about different waivers for peers because a lot of their peers have records. And so that hinders individuals from entering in. Also pipeline, how do you get people from starting at high school to start going into the field? And then looking at licensure and really highlighting not so much the examination, but more of the clinical supervision were also some strategies that some of the providers mentioned in that meeting. So any other questions that people may have, please come on up. Awesome.
Sorry, I was in the back. Judge, this question's for you. You alluded to, and really clarification on that, your program that you've got, is that under a judicial umbrella, or is that a county umbrella, or is that state? And just how do you receive funding from that, and what are the benefits of where you are?
So it's a two-part program. It's a pre-arrest diversion and a post-arrest diversion system. It's not a mental health court per se. That's kind of a small part of what we do, and that's why we have such a large staff. And so for our post-arrest, if you get arrested on a misdemeanor, we have the person generally transferred out of the jail within a few days to one of our crisis stabilization units. And we have a cooperative agreement where we actually reset the case for about 2 weeks because that's what most of this population really needs to stabilize. This 3-day thing is a legal number, not a medical number. And most people kind of think, oh, they can get stabilized in 3 days. That is not the case. And so we actually spend about 2 weeks, and then a member of our staff goes and meets with them and offers them an opportunity to come in our program. And if they accept, this is where we have some leverage, they do not get rebooked to jail. They go directly to the courtroom. There are peers waiting for them. We have, the county gave us a car. I'll address the money in a second. And we find housing for them. We get everything lined up for them, and then we help them navigate these systems. The recidivism went from 75 to 20% in our misdemeanor population. The state attorney realized, whoa, this is how you really improve public safety, and we expanded it to nonviolent felony cases as well. And we've added things along the years. We have an assisted outpatient treatment program. We have an alternative to competency restoration program. We've really figured out where the holes were, and we have filled them. It is under the court's umbrella. We call it the 11th Judicial Circuit Criminal Mental Health Project. The county funds some of those positions. The state funds some of those positions. The federal government funds some of those positions. So it's a blend of resources through grants and other recurring dollars, but it's worked. And we closed the jail, and our felony diversion program has saved the county 84 years of jail bed days. The pre-arrest CIT program saved the county 400 years of jail bed days. And a couple other things happened that we had not even anticipated. Our police shootings have almost stopped in Miami-Dade County. And so while race certainly can play a role in police shootings, what we found is that PTSD among police officers also plays a huge role. They get scared and they overreact. And so what happened is we get the woman that runs our CIT training she gets 250 calls a month from police officers for their own personal mental health issues. And so what we discovered is most departments, between 15 and 35% of the officers have severe PTSD. Many of them are returning vets that are getting re-traumatized, and some are getting traumatized on the department, and the last place they want to go for help is in their department. So now we have set up a peer program among police, and we have a program where we refer them to treatment outside the department. Last year in the United States, more officers died from suicide than in the line of duty. It's a horrific problem. But what we found is when we got our shootings under control as a result of this, the city of Miami was able to get its bond issue, their bond rating raised tremendously, because we know that you're self-insured as municipalities and counties. And so whenever there was a shooting, the city of Miami, before we had CIT, the 5 years before, had 90 police shootings, one department. They were spending hundreds of millions of dollars on lawsuits to pay off the suits, and it killed their bond rating. And they were able to reverse that once we got their shootings down. I think the last 5 years they were less than 12 or 13. And so it's really made a significant difference. And doing this helps everybody. Doing it for the right reason, you get the right results, and everybody wins.
Thank you so much. Any other questions? Well, I have another question. So there's quite a bit of silos with mental health on one side, addiction on another side, and you have folks who unfortunately are still kind of stuck in the status quo, right, of things. So how have you two been able to create innovative strategies to this mental health crisis as well as addiction crisis, right? How did you get buy-in from stakeholders to collaborate and really encourage this? You know, to think of the fact that you have now clinicians in the 911 center, when people call, they're like, I want 911. I don't want, I want this 911 right now. And then even to you, Judge, how were you able to get the buy-in, not only from individuals within, your area, but the community folks? I'll start with you.
Okay. Yeah, so buy-in, we have been able to really just uplift the successful stories that we have with our clinicians and our teams when they're out in the community, providing the resources that they're providing. So it's really critical to ensure that your data is meeting the needs of not only the people that are funding your services, but community advocacy groups. What is it that your advocacy in your community wants to know? Ensuring that you're getting that information and gathering that information to support the good work that your teams are doing. So qualitative and quantitative data has been really beneficial to keep not only sustaining but expanding the services that we have here in Travis County. And I would say that has been really critical. Outside of data, ensuring that you have good relationships. Relationships are key. So good relationships with your city and county governments, police, first responder partners, your mental health authorities, your hospital district systems. We have ongoing meetings, stakeholder meetings, quarterly meetings. I mean, so many meetings to ensure that we're all on the same page and working towards the common goal of getting people to the care that they need. So I would say from my experience, the relationships are key, and the data, gathering the data and providing that back out to the people that are funding the services is critical.
So that really is an important question, so thank you. Ours started in 2000 and making sure we had the right stakeholders. And I'll tell you, the first thing we were really good about is we didn't point fingers. This is nobody's fault. This is no one party or one institution or individual's fault. Some of this is well-meaning policies that just didn't work. And so it was not about looking back, it was about looking forward. And we had meetings every month for 10 years, and it just got too big. 200-300 people were starting to come to our meetings. But we have kept up by having annual meetings. We do a CIT Officer of the Year where we have all of our stakeholders. We have 500-600 people come to that event. And all the different stakeholders are there, and we make sure there's a lot of open lines of communications. We still have regular meetings. We still have outreach. It's not a perfect system, so we're always open to constructive criticism and making improvements as we move along. We're not overly sensitive. If it's not working, tell us, we'll fix it. And we've tried to maintain that attitude for 23 years, and I think we've been relatively successful at doing that. But a lot of it's just communicating, regular meetings, and having accountability and making sure that there's transparency and the system's working. And when it's not, sitting down with all the parties and working with them to make improvements.
Thank you so much. So another question would be, what is a lesson learned that you wish you would have known before you created the programs?
So thank you, because I was going to mention it anyway. If I had to do this again, 23 years ago at our first summit, I would have made sure I invited the superintendent of schools and members of our school board. Because we didn't know this 23 years ago. This is only data that's 10, 15 years old. But the vast majority of individuals in jails with serious mental illnesses have horrific histories of trauma. 92% of all the women in jails and prisons in the United States with serious mental illnesses have horrific histories of trauma, mostly sexual abuse. 75% of men in jails and prisons with serious mental illnesses also have horrific histories of trauma. Some of it is sexual abuse. More likely they have been victims of long-term domestic violence, or they have been witnesses to really horrible violent crimes. And what we know today, there's a professor actually right here at University of Texas who's a geneticist, and she believes they have identified about 21 genes that contribute to schizophrenia. And one of the two main triggers, if you have a predisposition, is trauma. And so what I would be doing today, and we probably could have saved generations of people coming into our system, I would be doing assessments. One of them I like is called ACEs. It stands for Adverse Childhood Experiences. And if you have a score of 4 or above out of 9 questions, we know you have almost a 100% chance of developing a substance use disorder and or a mental health disorder. And so, a lot of health issues. That's the third part of it. It's not just mental health and substance use, it's comorbidity. Most of this population also has horrific health problems, heart disease, cancer, diabetes, and those are not getting addressed. And so if we did early assessments, early middle school, late elementary, and identified trauma early, we could probably keep a lot of people from ever coming into our criminal system and allowing them to have lives of hope and opportunity.
Thank you so much, Jim.
I agree with that, and I would say the only other piece that I would say within our crisis continuum that we've recently integrated that I wish we would have done several years ago is the substance use piece and the peer integration. Our services, at least for crisis services, the peer integration started because the result of the pandemic and the workforce shortage, but we have seen how integral those services are to our crisis continuum. And then specifically the specialty substance use services within crisis services. So much of this is co-occurring, not just with adults, but with our children and adolescents. So lessons learned for us. We've seen the benefits of this in our last year and a half of integration, and if I could go back and do this 10 years ago, I would have started this 10 years ago.
Thank you so much for the wealth of knowledge. So just in one word, one, Judge, one, okay, one, all right? One, right, would be self-care, one word, because this is hard work. This is hard work. You can't unhear and unsee some of the stories that we experience, right? So one word, how do you take care of yourself? One word or two.
Walk every day.
I said, or two. Walk every day. Thank you, Judge. I know I'm a member with him too.
Sleep.
That's a good one. I wish I could sleep. So, listen, this I think that this highlights two different programs, right? And really highlighted that. I'm sure that other counties have other kind of innovative strategies that you all are doing, and so hopefully we all can collectively continue to come together and work with our county folks and NACO to really move the needle on this, because we're starting to. So listen, thank you all so much, and don't forget self-care.